Welcome to the deep dive. Today we're tackling a really vital topic, cancer pain.
Yeah, it's something that touches so many patients and families.
Absolutely. It's far more than just a physical symptom, isn't it? It can really weave its way into every aspect of someone's experience with cancer.
That's exactly right. So in this deep dive, we're going to explore why getting a grip on cancer pain is so critical. We'll look into, how common it is, the different kinds of pain people might experience.
And the ways to manage it effectively.
Right, based on what the research and guidelines tell us. The idea is to give a clear overview, sort of cutting through the noise to focus on what really matters.
Okay, sounds good. So let's start right there. Why is understanding and managing cancer pain so essential? What's the big impact?
Well, fundamentally, when cancer pain isn't managed well, it seriously degrades a patient's quality of life. It's not just the hurt. It can really ramp up anxiety, lead to depression. It messes with sleep, makes it hard to concentrate, even affects appetite.
Yeah, I can only imagine trying to navigate treatment, let alone daily life, while dealing with constant pain. It must be exhausting.
It is, and it digs deeper, too. Pain can actually shift how patients and even their families perceive the illness itself, the treatment.
How so? How does pain affect their view of treatment?
Well, think about it. If someone's in a lot of pain, they might lose their appetite, spend more time in bed, seem withdrawn.
Okay.
Their family might see that and think, oh, no, they're giving up. They might worry about abandonment, But the root cause might just be the pain that isn't being controlled properly.
I see. So it's not necessarily a lack of will, but the physical burden of the pain itself causing those behaviors.
Exactly. So managing pain well isn't just about physical comfort. It's also about maintaining hope, enabling better communication, and helping everyone understand what's really going on.
That really puts it into perspective. So how prevalent is this? Is cancer pain a relatively rare thing or quite common?
Unfortunately, it's very common. Take chronic pain after cancer surgery. Some studies suggest it happens in up to, 50% of patients. Half.
Wow, 50%. That's a huge number. Are there specific factors that make someone more likely to develop this persistent pain after surgery?
Yeah, there are known risk factors for breast cancer surgery, for instance. Things like being younger, having had chemo or radiotherapy, not having good pain control right after the surgery.
Right.
And even surgical techniques can increase the risk. And then there's pain specifically from radiotherapy nerve pain or neuropathic pain. It might be less frequent overall, but when it hits, it can be really persistent and disabling.
Okay, so you mentioned neuropathic pain. It sounds like cancer pain isn't just one single entity. It's more complicated.
Oh, absolutely. Cancer pain is often really complex. That's why we often need what's called multimodal therapy.
Multimodal, meaning hitting it from different angles.
Precisely, using a mix of treatments. And often, the toughest nut to crack, the most intractable pain, is that neuropathic type.
And that's the pain coming directly from nerve damage, is that right?
Yes, exactly. It happens when the tumor itself grows into or presses on parts of the nervous system. That could be the membranes around the brain and spinal cord, the meninges and dura, or the spinal cord itself.
Or the nerves branching out.
Right. The nerve roots coming off the spine, bigger nerve networks called plexuses, or the smaller peripheral nerves out in the limbs and body.
So what's happening on a biological level? Why does this nerve invasion cause pain?
Well, at its core, you've got damage to the neurons, the nerve cells. This could be in the peripheral nerves or the central nervous system.
Okay.
The damage might come from compression, like the tumor squeezing a nerve, or it could be from lack of blood flow ischemia or bleeding near the nerve, or even chemical irritation from the tumor. Sometimes surgery itself can cut or transect a nerve.
And this damage, it changes how the nerve works.
It does. A key thing that happens, especially with peripheral nerve injury, is you get this buildup of abnormal sodium and calcium channels right at the injury site.
Channels, like little gates in the nerve cell membrane.
Exactly. They control how electrical signals, including pain signals, travel along the nerve. When you get too many or abnormal ones clustering at the injury site, the nerve becomes hyperexcitable. It starts firing off pain signals inappropriately. That's what causes those burning, shooting, tingling sensations typical of neuropathic pain.
Like faulty wiring.
Kind of, yeah.
Yeah.
It's a good analogy.
You also mentioned central pain pathways earlier. How do they fit in?
Right. So besides the signals coming up from the body, we also have pathways coming down from the brain. These start in parts of the brainstem areas called the periaqueductal gray, or PEG, and the rostroventral medulla, RVM.
Okay.
And these descending pathways connect down to the spinal cord, specifically the dorsal horn, That's like the first relay station where pain signals from the body enter the central nervous system.
And what do these descending pathways do? Do they amplify the pain or?
Well, here's where it gets really interesting. They can do both. They can either inhibit pain signals, turn the volume down, or facilitate them, turn the volume up. For example, pathways using the chemical messenger norepinephrine tend to be inhibitory. They help suppress pain transmission. But serotonin, another messenger, is more complex. Depending on which specific receptor it hits in the dorsal horn, it can either reduce pain or actually enhance it.
So the brain has its own built-in system for controlling pain signals, but it can work both ways.
Exactly. It's a dynamic modulation system.
That's incredibly complex. So when you're assessing cancer pain, how does it differ from, say, assessing pain from a sports injury?
It's a much broader assessment needed for cancer pain. You absolutely have to look at the patient's specific cancer history. What type of cancer, what stage it's at.
Right.
You need to understand the specific pain syndromes. Is it bone pain, nerve pain, visceral pain? And you also need to consider their past experiences with pain and any history of substance use. It's not just asking, where does it hurt?
Much more context required.
Definitely. And there's a psychological dimension too. Often patients experiencing acute pain directly from their cancer or treatment cope with it reasonably well, psychologically speaking.
Why is that?
Because they often understand it's likely temporary. They know it might get better as the treatment works or as they heal from surgery. There's an endpoint in sight, potentially.
Ah, okay. That's different from chronic pain that just lingers.
Exactly. Someone with severe chronic cancer pain might not even show those classic signs of acute pain, like sweating or a fast heart rate. Instead, you might see them guarding the painful area, being very still. And emotionally, you might see more anxiety, depression. Maybe they withdraw socially or become irritable. It presents differently.
And just to add another layer, sometimes, though it's rare, people without cancer can develop pain syndromes that look very much like typical cancer pain.
So you always need that full picture. Now, we often hear terms like acute and chronic pain. How are those generally defined?
Yeah, the standard definitions, like those used in the CDC guidelines, typically classify pain by duration. Acute pain is usually less than a month.
Okay.
Subacute pain lasts between 1 and 3 months. And chronic pain is anything persisting for more than 3 months. And recognizing these durations is important for treatment.
Yes, because the approach might differ. And it's really important to remember that chronic pain, whatever the cause, often goes hand in hand with other issues.
Like what?
Behavioral health conditions are common. Things like depression, anxiety, sometimes substance use disorders can co-occur. And very seriously, chronic pain is associated with a higher risk of suicidal thoughts and actions.
That really drives home the need for comprehensive care, addressing the mental and emotional side too.
Absolutely crucial. You have to treat the whole person, not just the pain score.
Okay, let's shift towards managing the pain. I know the WHO analgesic ladder has been a standard. Is that still the main framework?
Well, the sources we looked at don't explicitly map everything to the traditional 3-step ladder, but the core principle is definitely still there. A stepwise approach. Start simple for mild pain and escalate if noted.
So, step 1. What are the initial go-to options for milder pain?
Typically, you'd start with non-opioid medications. The main players here are acetaminophen paracetamol and NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen or naproxen.
Right.
These can be quite effective for managing mild to moderate symptoms in many chronic pain conditions, including cancer-related pain. And often, we think about multimodal analgesia right away.
Using combinations from the start.
Yeah, potentially. Like maybe combining acetaminophen with an NSAID or adding a drug that targets nerve pain like gabapentin or pregabalin, even if the pain seems mild, especially if you suspect a nerve component.
Trying to cover different pain mechanisms.
Exactly. Attack it from different directions.
Are there downsides or risks we need to watch out for with these initial drugs, acetaminophen and NSAIDs?
Oh, yes. Always. They're not without risks, especially for older adults or people with other health problems. NSAIDs, particularly with longer-term use, carry risks of stomach ulcers, bleeding, and cardiovascular issues like heart attack or stroke. And even acetaminophen, while often seen as very safe, needs care in people with liver issues. And some of the adjuvant drugs, like anticonvulsants used for nerve pain, can have side effects like drowsiness or dizziness.
So, patient selection and monitoring are key. What if these initial steps aren't cutting it? If the pain is moderate or getting worse?
Okay, so if mild approaches aren't enough, we might move to what you could consider the next step up, This often involves introducing weaker opioids or low doses of stronger ones.
Such as?
Our sources mention options like low-dose oxycodone, often starting at quite small amounts. Also drugs like tramadol and tapentadol, which have slightly different mechanisms but include opioid activity.
Okay.
Sometimes you'll see combination pills, like a low dose of oxycodone mixed with acetaminophen or an NSAID.
And what should patients know about these?
Well, they can be quite effective for that mild to moderate pain level. Oxycodone, for example, can sometimes cause a bit of mild euphoria, which isn't necessarily a goal but can happen. A more common issue is constipation that's almost universal with opioids and needs active management from the start.
Right, managing the side effects.
Definitely.
Yeah.
For many people with, say, moderate bone pain that comes and goes, these agents can work really well. One interesting point from the sources is that some research suggests women might get higher blood levels of oxycodone than men from the same dose.
Really?
Yeah, so it might be sensible to consider starting female patients on a slightly lower initial dose just to be cautious about side effects.
That's a useful clinical pearl. Okay, so now we're firmly in opioid territory. These are obviously powerful painkillers, but also come with significant concerns and stigma. How are they viewed specifically for cancer pain?
It's a really important distinction. While there's rightly a lot of caution around opioids for chronic non-cancer pain, for moderate to severe cancer pain, opioid therapy is often considered the cornerstone, the mainstay of analgesia, according to our sources.
Okay, so still a critical tool.
A critical tool. And for patients who are already on a regular, around-the-clock opioid dose for their background pain, having access to short-acting, immediate-release opioids is vital for managing breakthrough pain.
Those sudden flares of intense pain.
Exactly. You need something that works quickly for those episodes.
How are these opioids typically given?
The good news is that for most patients, over 90% in fact, we can achieve good pain control using opioids taken by mouth, oral, or through the skin, transdermal.
So pills, liquids, patches.
Yes, lots of options. We have various liquid formulations, immediate-release tablets or capsules, sustained-release versions that last longer, and for transdermal, fentanyl patches are common.
What about patients who can't swallow easily or maybe have a feeding tube?
Good question. For them, we can use liquid forms of morphine, oxycodone, or hydromorphone. Methadone also comes in a liquid, or tablets that can be crushed and dissolved in water for tube administration. So there are usually ways around swallowing difficulties.
And the fentanyl patches, when are they the best choice?
Patches are really useful for patients with stable, chronic pain who maybe struggle to take pills regularly, perhaps due to nausea or swallowing issues, or just prefer the convenience of a patch they change every few days.
How long do they take to work?
That's a key point. They're not for immediate relief. It takes time, typically 14 to 20 hours, for the fentanyl to absorb through the skin and reach steady levels in the blood. So they're for managing stable, ongoing pain. They're usually changed every 72 hours, though sometimes every 48 hours is needed for consistent effect.
Okay. Now, I've also heard about opioid switching or rotation. What's that about?
Right, opioid rotation. Sometimes a patient might be getting decent pain relief from one opioid, but the side effects like severe nausea or confusion are just too much. Or maybe the pain relief just isn't good enough, even after increasing the dose.
So you try a different opioid.
Exactly. We carefully calculate an estimated equivalent dose of a different opioid and switch them over, titrating the new drug cautiously. Why it works isn't perfectly understood. People metabolize opioids differently, and different opioids might interact slightly differently with the opioid receptors, but it can sometimes significantly improve the balance between pain relief and side effects.
Interesting. Are there other less common effects of opioids we should be aware of?
One important one is something called opioid-induced hyperalgesia.
Hyperalgesia, meaning more pain.
Yes, paradoxically. It's a situation where, as you increase the opioid dose, the patient actually becomes more sensitive to pain. Their pain might worsen or spread or change character.
Yeah.
It's not the same as tolerance, where you just need more drug for the same effect.
So more opioid equals more pain. How do you deal with that?
If hyperalgesia is suspected, the approach is actually to carefully reduce the opioid dose, or sometimes switch to a different opioid that might be less likely to cause it, like methadone. It's complex and needs careful assessment.
Definitely sounds tricky. Let's talk about administration again. You mentioned oral and transdermal are common. What about injections? You said intramuscular is a no-go?
Correct. For ongoing cancer pain management, intramuscular IM injections of opioids should generally be avoided.
Why is that?
Two main reasons. The injections themselves hurt, which is the last thing a patient in pain needs, And perhaps more importantly, absorption from the muscle can be really erratic and unpredictable. You can get variable blood levels, leading to peaks and troughs in both pain relief and side effects.
Okay, so no IM. What if someone is in truly severe, maybe even excruciating pain and needs relief fast? Oral meds might take too long.
That's where intravenous or IV administration comes in. For severe acute pain crises, carefully titrating opioids intravenously using small, frequent bolus doses is often the safest and fastest way to get pain under control.
Titrating meaning adjusting the dose based on response.
Exactly. You give a small dose, assess the effect on pain and side effects like sedation or breathing rate, and give another small dose if needed, repeating until the pain is relieved. The dose is tailored to the patient, considering any opioids they're already taking.
Can you give an example?
Sure. Imagine a patient comes in with severe uncontrolled pain from bone metastases. They might already be on oral opioids at home, but it's not enough. We can start an IV, give calculated bolus doses of, say, morphine or hydromorphone every few minutes until their pain score drops significantly. Then, based on how much opioid it took to get them comfortable, we might start a continuous IV infusion.
That sounds much more controlled than just giving a large shot.
It is. It allows for rapid relief while minimizing the risk of giving too much too quickly. Trying to achieve the same level of relief fast with only oral medication in someone who hasn't taken opioids before, opioid naive, would be much slower and potentially riskier due to unpredictable absorption.
But you still need to be cautious, especially with opioid-naive patients using IVs.
Absolutely. You have to monitor them very closely for sedation and respiratory rate. Rapid dose escalation is dangerous in someone not used to opioids. It's normal, though, for patients to become quite sleepy once their severe pain is finally relieved. They're often exhausted.
So sleepiness doesn't automatically mean overdose.
Not necessarily. If they're easily woken up and their breathing is fine, it's often just relief and exhaustion. But if they become difficult to arouse, you'd stop the opioid temporarily, maybe give naloxone if needed, and restart at a lower rate once they're more awake. Close monitoring is key.
Okay. Is there any specific opioid that's particularly problematic or best avoided?
Yes, the sources specifically caution against using meperidine, also known as Demerol, for chronic moderate to severe cancer pain.
Why meperidine specifically?
Because it gets broken down in the body into a toxic metabolite called normeperidine. This substance can build up, especially with repeated doses or in people with kidney problems or dehydration.
And what does normeperidine do?
It's a central nervous system stimulant. It can cause agitation, tremors, muscle twitching myoclonus, and even seizures. And here's the really tricky part. Naloxone, the standard opioid reversal agent, doesn't reverse normeperidine toxicity and can actually make the seizures worse.
Wow, so definitely one to avoid for ongoing pain.
Generally, yes. There are much safer and more effective opioid choices available for cancer pain.
It really sounds like effective pain control is rarely about just one drug, doesn't it?
Absolutely. It goes back to that multimodal approach, combining different classes of drugs, opioids, NSAIDs, acetaminophen, drugs for nerve pain like gabapentin or pregabalin, maybe corticosteroids for inflammation or bone pain.
And other treatments, too.
Yes, depending on the situation. Sometimes bisphosphonates or ORANG-KL inhibitors are used specifically for bone pain. And don't forget non-drug approaches. Patient education itself can help reduce pain perception, physical therapies, relaxation techniques.
Interventional techniques. Sometimes, yes. Things like nerve blocks, epidural catheters, spinal analgesia, or even neuroablative procedures for really refractory pain, though that's less common.
It really highlights the need for specialized knowledge.
It does. This is where palliative medicine specialists really shine. They have deep expertise in opioid management, dealing with side effects, understanding the nuances of different cancer pain syndromes, and crucially, having excellent communication skills to work with patients and families.
So putting it all together, it's a complex field, but effective management is possible.
Definitely. It requires a thorough assessment, an individualized plan, often using multiple tools, pharmacological and non-pharmacological. But yes, good pain control is achievable for the vast majority of patients. This has been incredibly insightful. We've covered the sheer importance of addressing cancer pain, the different types, the stepwise approach to analgesia starting with non-opioids, the crucial role and careful use of opioids, including different formulations and managing risks like hyperalgesia and avoiding drugs like meperidine.
And touching on that vital multimodal concept, combining strategies for the best effect, it's clear that a one-size-fits-all approach just doesn't work here.
Not at all. And as you said, there's even more depth we could explore in supportive care and specific techniques later on.
For sure. Lots more to discuss.
Okay, well, to wrap up this deep dive, here's something for all of you listening to consider. What do you think is the single biggest misconception patients and their families hold about cancer pain or its treatment? And how can we, as healthcare communicators or providers, do a better job of addressing that? Something to mull over. Thanks for joining us.